It is an injectable, whereas a DPP-4 inhibitor is oral. There is always the constraint, the barrier of starting a patient with an injectable therapy as opposed to an oral therapy. I come from a very physician-oriented background. My father-in-law, my husband, my mother-in-law, everybody's a physician. I chose out of it because I have too many white coats and aprons and stethoscopes around my house. So I know how it works, and I know the fears and the constraints that people face. Over the next 15-20 minutes, I'd like to take you over the benefits of liraglutide. I'm not here to demean anybody's product. I'm not here to tell you that, oh, acetagliptin is not good or linagliptin is not good. I'm here to tell you why liraglutide is better and where in the continuum of diabetes therapy you can place it. So what is liraglutide? We have already established that it is a GLP-1 analog. What you need to further know that GLP-1 analogs, there are two types in the market. One is a human GLP-1 analog and one is an exendin-based therapy. Exendin is derived from the saliva of a lizard known as Gila monster. Okay, so exenatide is actually made from the saliva of that Gila monster. So the homology to human GLP-1 is not as much as liraglutide and the subsequent human GLP-1s that are coming up in the market, like lixisenatide. Lixisenatide is also a human GLP-1 analog. This is the structure of native GLP-1, that is your endogenous GLP-1, which is present in the body. And this is liraglutide. Two structural modifications have been made. As you can see over here, in the 34th position, lysine has been replaced by arginine, and we have added a glutamic acid and a C16 fatty acid palmitoyl chain over here, which is not added over here, to make it resistant to DPP-4 in the body. So these changes make it not only resistant to DPP-4, it increases the half-life from 1.5 to 2 minutes to 13 hours, right? So a lot of people ask me this question: is there any role in combining liraglutide with a DPP-4 inhibitor? No, there isn't any. DPP-4 resistant molecule is liraglutide. What you're going to be doing by giving a DPP-4 inhibitor with liraglutide doesn't make any sense, because liraglutide by itself is long acting. It has a 13-hour half-life. So it really is not going to be any further effect by trying and increasing endogenous GLP-1. It's not going to have any effect. Maybe with the short-acting GLP-1, maybe with exenatide, it might have some effect, but with liraglutide, there is no justification of adding a DPP-4 inhibitor with this molecule. So where can we place liraglutide in the continuum of diabetes care? This has been evaluated by a series of studies known as LEAD, which is liraglutide effect and action in diabetes. So it was assessed as monotherapy immediately after diet and exercise against a glimepiride. It has been assessed as combination with another drug with a sulfonylurea versus a thiazolidinedione with metformin versus a sulfonylurea. So in combination with two drugs, in combination with one drug, then it has been added in combination with two drugs, that is metformin plus TZD. It has been assessed with that. Then of course, how can we try and place it as compared to insulin? So that was also assessed. Liraglutide versus the most commonly used basal insulin, that was glargine, in combination with two other OADs. And of course, liraglutide versus exenatide, which was the only available other GLP-1 analog then when the LEAD studies were being done. So this is how the LEAD studies have been placed. I'm not going to take you through individual LEAD studies because I would be here perhaps for 4 hours if I have to discuss each and every aspect of all the LEAD studies. I'll just give you an overview of what all the LEAD studies have shown. Right, so liraglutide has been shown to be effective in reducing fasting as well as postprandial glucose levels. The fasting levels, we have compared this with glargine, because as we know, being a basal insulin, it has the significant reduction in fasting plasma glucose levels. So you can see here the difference in fasting plasma glucose levels is non-significant. That is, both insulin glargine as well as liraglutide have reduced to similar levels. Then coming on to postprandial glucose levels, all the lead studies have been plotted over here for your reference, whether it's lead 3, 2, 1, 4, 5. There were 2 doses of liraglutide which were used in these lead studies. The blue one is 1.2 mg and the maroon bar is 1.8 mg. So there has been a significant reduction in PPG across all lead studies to the tune of about 36, 2.5 millimole. That's roughly around 40 milligrams per deciliter, between 35 and 40 milligrams per deciliter. So that's quite a significant reduction. When in monotherapy was compared with glimepiride, the reduction in HbA1c is pretty much visible for everybody. With 1.2 milligram, there was a reduction of 1.2%. With 1.8 milligram, there was a reduction of 1.6% as opposed to 0.9% with glimepiride. This was the HbA1c reduction across all the lead studies. Put it in one slide for you. So you can see in monotherapy, I just discussed it individually. In combination with metformin versus a glimepiride, there was a more significant reduction, 1.3 versus 1.1. In combination with a sulfonylurea compared with rosiglitazone, a TZD, again a 1.5% reduction as opposed to 0.8 with rosiglitazone. In combination with 2 other agents, metformin plus rosi, there was a 1.5% reduction, and as compared to insulin glargine, that was also significant, 1.3 versus 1.1 with insulin glargine. Then comes your targets. Lots of guidelines, lots of targets. ADA, AACE, IDF, NICE. I don't know how many of you follow ADA or how many follow AACE. I don't know the division, but over here we discussed the ADA targets being achieved. The ADA targets, I think most people practice the HbA1c target being less than 7% as opposed to the stricter target of AACE, which is 6.5% because of the increased chance of hypoglycemia. So over here, the number of patients who have achieved the ADA target of HbA1c less than 7% has been significantly high across all lead studies. I'm not going to read out individual values. I think it's pretty visible for everybody to see. The blue and the maroon bars are higher in all the lead studies compared to all other comparators. Taking this further, those patients who had higher HbA1c have shown greater reduction in HbA1c. But I guess that is pretty obvious or self-explanatory. The higher your weight, the more your weight loss, the higher your HbA1c, the greater your HbA1c reduction. So in lead 2 studies, subjects having baseline HbA1c of more than 9.5%, there was almost a reduction of 3% HbA1c. That's quite a large amount. Then comes the question of beyond glycemic control. Type 2 diabetes is associated with a lot of factors. First, obesity. Second, high blood pressure. Third, dyslipidemia. So does liraglutide address all of this? Any GLP-1 analog for that matter has a potential weight-losing effect. You can see this is a controlled trial, this is the clinical trial result. There has been a 2.5 kilo weight reduction with liraglutide in monotherapy. Further taking it, waist circumference was also reduced, and I think abdominal obesity, a lot of you will agree, is definitely a problem with Asians and in type 2 diabetes as well. How has this been measured? It's not only weight, this has been also shown in a DEXA body scan and also in visceral versus subcutaneous fat. There was a significant reduction in visceral fat as opposed to subcutaneous fat, and I think that is a very, very important finding. I'm sure all of you would agree that visceral fat is something which definitely is a risk factor. And overall, there was a change in body fat by the DEXA scan. Next, coming on to the blood pressure. Consistently across all lead studies, liraglutide has shown to reduce systolic blood pressure quite significantly. Up to 3.6 millimeters of mercury in one, 2.8, 2.8, 6.6 in combination with metformin and thiazolidine. That's a huge number, that's a significant thing. A lot of us do treat hypertension along with diabetes as well because it's a comorbidity and it's an added cardiovascular risk factor. So why not give one molecule which would also give you this added benefit and advantage of reducing your systolic blood pressure as well as your lipids to a certain extent. Then comes the beta cell function. There are two models. A lot of you would argue that the HOMA-B, which is a mathematical model, is not really the best thing. Fine, I would take it, but currently these are the only two models which are available to assess beta cell function. HOMA-B is a mathematical model, and of course we have the good old pro-insulin to insulin ratio. So for argument's sake, I will ignore the HOMA-B model because there's a big controversy whether that is actually a good parameter. So we'll go on to the pro-insulin to insulin ratio. Again, this ratio, if your pro-insulin to insulin ratio is lower, that is in the negatives, that means there is a larger secretion of insulin. So that is quite a significant reduction. You can ignore the HOMA-B model if you're not comfortable with it. Of course, everything is not good about a molecule. It cannot be. Yeah, if there's something, so many positive effects, there's got to be some side effects as well. And you know your molecule is working only if you have side effects to therapy. So what are these side effects that we see commonly in therapy? First, I'd like to deal with hypoglycemia because any new anti-diabetic agent that comes onto the market, the fear of hypoglycemia remains. Is there hypoglycemia with liraglutide? Very, very minimal. Yes, there is, of course there is, or else it wouldn't be an anti-diabetic agent. It obviously is going to reduce blood sugar, so there will be hypoglycemia, but very, very minimal, to the tune of 0.1 event per patient per year, as opposed to, you can see glimepiride, and I do not have the collated data of the other lead studies, but if I do get an opportunity to come back again to present that, I will definitely show it to you. The most important side effect, which is the most troublesome for all patients, is the nausea that occurs with liraglutide. And that starts off as soon as you start the injection. That is quite a deterrent in the treatment of any GLP-1 analog. But here, as physicians, the counseling of the patient becomes very, very important because, as you can see from this graph here, the nausea is there very high in the initial period, and that's only because the patient doesn't know how to adjust his or her meal size according to the fact that there is a slowing in the gastric emptying time. Once the patient gets aware of how much food to eat, this nausea automatically reduces. So between 8 to 10 weeks, it's more or less acceptable, and by 12 weeks you can say it's almost negligible in comparison with your standard glimepiride, which is the commonly used sulfonylurea in the market. So yes, there is a high amount of nausea, but again, patient persistence and counseling is very important here. If they can be asked to hold on to therapy for just about 3 months, this will go. And once the patient is aware of the benefits, he's experiencing the benefits of the molecule, this nausea becomes immaterial. Now the question is, how is liraglutide different from gliptins? Right. The first and foremost point is the mechanism of stimulation of insulin secretion is exclusively through GLP-1 effect. That is a proven fact with the GLP-1 analog. With the DPP4 inhibitor, there is no studies to prove the same. Yes, we are assuming that endogenous GLP-1 is increasing and that is why, but what other ways it's happening, that's an unknown phenomenon. Right? Secondly is the glucagon suppression. I'm only going to take you through the differences which are significant. The glucagon suppression, DPP4 inhibitors don't have the capacity to do that, whereas a GLP-1 does. Then comes the inhibition of gastric emptying. Yes, very much present in GLP-1, but marginal with the DPP-4 inhibitor. As a result, the effect on weight, DPP-4 inhibitors are weight neutral, whereas GLP-1 agonists cause weight loss. Now comes the two most important points which you would use against me, because I've used all of this against you. First and foremost is administration. Yes, GLP-1 is subcutaneous, whereas the DPP-4 is oral. And the side effects of nausea is absent with DPP-4 inhibitors, where it is quite significant with the GLP-1 analog, any in the market. How you'd like to balance these two over these three above is where you as physicians come in and how your counseling and dealing with patients come in. I'd like to show you a few important slides which will highlight the advantages of a GLP-1 over a DPP-4 inhibitor. So what was done was, again, GLP-1 levels were measured, endogenous GLP-1 levels were measured after giving liraglutide and after giving vildagliptin. So vildagliptin was given for 28 days in a dose of 100 mg twice daily, and liraglutide was given in a dose of 6 microgram per kg for 7 days. And after that, for one whole, the therapies were stopped and GLP-1 levels were measured in the body. So I think it's pretty significant and explanatory, the difference. Gliptin will be raising your endogenous GLP-1, whereas when you're giving it exogenously, the GLP-1 concentration would definitely be higher. So that is where the main difference lies in therapy. And we have seen that GLP-1 is a significant marker, is there in the pathophysiology of type 2 diabetes. So why not give a molecule which will raise GLP-1 levels to at least physiological levels. A head-to-head study was done with sitagliptin, which is the most commonly used DPP-4 inhibitor. It was a study of 26 weeks, was extended for a further 26 weeks, and then there was a switch over done. Those patients who were on sitagliptin for that 1 year were shifted to liraglutide for the further 26 weeks that the study was extended. Mean HbA1c reduction, I think a lot of you who are using gliptins in clinical practice would agree that it has a limited HbA1c reduction. I get that from the remaining physicians. It's just the convenience of giving it orally, which scores over a GLP-1. So a mean reduction of 0.9% as opposed to a 1.5% in HbA1c reduction was seen. Definitely more people reached both ADA goal as well as the AACE target goal of either 7% or 6.5% with liraglutide compared to sitagliptin. Body weight change, huge difference, a loss of around 3.5 kilos with liraglutide as opposed to just about a kilo with sitagliptin. Then we did something which we thought would help physicians understand why a GLP-1 should be scored over a DPP-4 inhibitor, and we did a direct treatment satisfaction questionnaire survey which we gave to all the patients who were in the trial, and you can see the results. Pre-treatment is the lighter bars and post-treatment is the darker bars. There has been an improvement in treatment satisfaction across all the groups, but it was significant statistically with the liraglutide group only. So it's not only about achieving your targets by giving an oral thing. The question of satisfying your patient, him having a good feel factor also is an important thing in treating diabetes. So how is liraglutide placed in therapy? Anywhere. You can start it off as monotherapy. You can give it after one agent, that is metformin failure. You can give it in combination with 2 oral agents as well. Is it approved for monotherapy? Yes, it is approved for monotherapy, very much so. The latest ADA EASD 2013 patient-centric guideline places a GLP-1, it places everything. Yes, but I would be highlighting GLP-1 over here because I'm talking about liraglutide after metformin failure. It can also be given in combination with 2 drugs, as shown down here. The AACE algorithm, monotherapy. In those patients who have 6.5 to 7.5%, they have said monotherapy. Those patients with HbA1c up to 9%, you start off with dual, metformin plus GLP-1. A1C more than 9%, you start off with a dual or triple therapy if you're not starting off with insulin, metformin plus GLP-1. So you have it across the continuum of care. Where you want to place it is your discretion, but it is approved for all stages. The next question which everybody asks or would like to know is how to start and how to titrate liraglutide. The initiation dose of liraglutide is available in a pre-filled pen. Okay, it's available in a pre-filled pen. You start off with 0.6 mg per day subcutaneously. This is to ensure tolerability. You wait till the patient gets used to the nausea for about 7 to 10 days. Then you up titrate it to 1.2 mg. In Indian setting, let me tell you, 1.2 mg works pretty much fine. You do not need, in most cases, to up titrate it to 1.8 mg. Most physicians I talk to, they have good results with 1.2 mg, but there is a scope in resistant patients who are quite morbidly obese with high PPG levels, with high fasting levels, high HbA1c. You can take it up to 1.8 mg as well. As I've told you, it's available in a pre-filled device, and you can give the injection irrespective of meals at any time of the day. And because there is such limited chance of hypoglycemia, you do not need to do your conventional SMPG, that is self-monitoring of blood glucose. This is how the company takes it forward. This is how Novo Nordisk tells you to up titrate. Let me tell you what I have spoken to Dr. V. Mohan of Mohan's Diabetes Center in Chennai in a 1:1 in a national conference when I met him. And I asked him, he is one of the highest prescribers of liraglutide in Indian market. He has about 1500 patients on liraglutide. And I asked him, sir, this is the way in Calcutta a lot of people tell me, they nausea, coughs, this, that. He said, Rajni, I start my patients with 0.6 mg. You guys tell us to keep the patient on 0.6 mg for 7 to 10 days. I keep my patients on 0.6 mg for a month. None of my patients have nausea. This is from one of the pioneer of diabetes. And he is using liraglutide in routine practice, and he currently has 1500 patients on liraglutide. You don't have to do it by Novo Nordisk standards. You can do it as per your standards, as per your patients. Okay? So if you are seeing that despite after 10 days 0.6 mg is still having nausea, wait. Don't discontinue. Wait. Take it to 2 weeks, take it to 3 weeks, take it to a month, and then see if the patient can take it up to 1.2 mg. Some practical tips I learned from Dr. V. Mohan and some of the other important figures, Dr. Balaji, Dr. Shishaya, in discussion with them. Choosing the right patient is very, very important. Not anybody and everybody can be started on liraglutide. Get your patient profile right, your patients will stick to therapy. A lot of complaints I get, there's a high attrition rate, there's a high dropout. Choose your patients well. Go for somebody who is perhaps young. Go for somebody who's in a metformin failure. Go for somebody whose beta cells need to be preserved. Go for somebody who is willing to take the injections. As I understand, in your center, it's a reimbursable center. For you, the cost shouldn't be a problem. Am I right, Sriparna? It's a reimbursable thing. So, yes, it's not an out-of-the-pocket market, so cost should not be an issue here. You have to counsel your patients about the side effects. It's very, very, very important. In any therapy, it's important. whether glycemic, non-glycemic, GI side effects, benefits. If you're telling your patients that there's going to be nausea and abdominal pain and oh, you're not going to be able to eat, please tell them you're going to lose weight. You're going to reduce your systolic blood pressure. It's not only about telling the side effects of the medicine, you need to explain to them the benefits also. That's where physicians are lacking. I have heard myself in front of a doctor, oh, there's a medicine. It's an injection, it's very expensive and it's going to cause nausea. Take it if you want. Nobody's going to take it. Nobody is going to take it. You as a patient will not take it. There is a way to even counsel the patient. If you want the benefit of the molecule, it has to be explained properly. Nobody is telling you to hide the side effects of the molecule. Nobody is. But there is, of course, a way to portray the message across so that the patient can understand the risk-benefit ratio. If he feels I'm going to be benefited, then and then only he'll take. If you're only trying to scare the patient in the long run, it's never going to work. Addressing GI side effects, some things I've learned from my interaction with physicians who are using GLP-1 in the long run is, yeah, as I've already mentioned, you can keep your patients on 0.6 mg per day for a longer period of time, maybe up to a month. Injecting in the evening time. Again, there is no real data on this. If you ask me to present data which is going to show you injecting in the morning versus injecting in the evening is going to cause less nausea, I don't have data for this. But physicians who are using it have said that relatively fewer complaints of nausea comes if the injection is given in the evening. It doesn't matter what time of the day you give it, as long as you're giving it at the same time of the day. That's important. So perhaps because lunch happens to be a heavy meal for Indians, that is why maybe giving it in the daytime causes more nausea. I don't know, probably that's an explanation. Avoiding fatty meals is a way. Taking small frequent meals is definitely a way. And yes, some people have said taking ginger extract helps reduce the nausea. I don't know. I don't know if that works, but I thought I should share with you some of the tips I got from other physicians. Maybe that would help you initiate Victoza or Liraglutide in your clinical practice. Thank you very much for your patient hearing. If you have any questions, I take it right now, and my contact details are also below for future calls.